Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Well, we have a great day today. We've got a guest from California, the owner of Pacific Point Podiatry in Aptos, California, and she is a leader in our profession in direct care. Welcome to Dean's Chat, Dr. Nguyen.
Thank you so much for having me, Dr. Jensen.
Oh, it's great to have you here. Just a little bit of a background. Dr. Nguyen did her undergraduate work at the University of San Diego, getting a degree in biology. She went on to her podiatric medical training at the Des Moines University College of Podiatric Medicine and Surgery. She did a 3-year medicine and surgical residency program in Detroit, Michigan at the Macomb Hospital. And then she also did a fellowship at UT Southwestern in wound care and surgery. And now you're in practice in California. Again, welcome. And Dr. Nguyen, we'd like to keep it informal on Dean's Chat. If it's okay with you, let's go with Jeff and T.
Let's do it.
All right. Sounds good. So you are a huge proponent of direct care. I follow you on social media. I've listened to some of your podcasts. You've been on other podcasts. And I admire your entrepreneurial spirit. But not only do you have a direct care practice, but you're also helping other professionals get involved in direct care. And probably the place to start is let's define direct care. What is direct care, T?
Direct care is practicing medicine without insurance interference. So when somebody has a foot and ankle problem and they want it solved, they can easily make an appointment. All they have to do is pay me directly. It's a seamless transaction. It's a lot like when you go get your hair cut. You need the haircut, you pay them, and that's it.
Seems kind of a dream come true. There's no pre-authorization, there's no bureaucracy, there's no denials for insurance, but it's not without its challenges, I imagine.
Exactly.
So I was on your website and I saw some of the accolades you've gotten from your practice. And I noticed that you've got your 3-month program that you put on to help podiatrists or other professionals begin a direct care practice. And sometimes it's a transition, right, out of what we would consider a traditional practice with insurances. How did you come up with a 3-month program to help your colleagues get into direct care?
Back when I opened my practice in 2018, I only knew about consultants. So I worked with consultants and it just never aligned with where I wanted to go. They helped me like the starting up phase. You need to have these systems in place, but then it never really took me to where I wanted, which was freedom in my schedule without the burdens of paperwork. But to be honest, I didn't know that's what I wanted because nobody really talked about a cash practice back then. So I had gone through several business coaches, consultants, and I just never felt at ease with business. And in fact, I wasn't doing very well. I was financially sinking. And I had to step back and say, what's going on? Is it because I can't do business math or is there something bigger? And I looked back and all of my overhead expenses accounted for things that accommodated insurance, like the AR, the billing service, the billing person who has to help me figure out the correct codes, the modifiers that keeps changing, all of these things, not just the financial cost, but the headaches. Nobody really explained that to me in black and white. It was just you learn as you go. So I had learned about a cash practice that was easier and made it nice for patients to access. And I was like, that's what I want. But there was no pathway to it. People were available. They were really friendly about their cash practices and said, well, these are the things that I went through personally, when I was talking to them about how they made it work. But it wasn't really easy for me to follow because I had my daughter the same year I opened my practice. And so I was kind of juggling 2 kids. And then I was also juggling with the identity of being a wife. And do I continue to work professionally or do I have to scale back and hold back my professional growth? So I had a lot of stuff going on, which meant having kind of a roadmap was even more essential for me, but it really never existed. So I struggled a lot in building my direct care practice. So once I created my direct care practice, I was like, how can I do this for others so that they have something to work with? And it's not just stuff you Google up, things you find on Facebook posts. Like it needs to be coherent and it really needs to hit major markers as it pertains to business, but a direct care practice. And so I thought 3 months is tolerable, but on the real side, might take 1 to 2 years to actually figure out if it's even for you, and then what pieces you have to put in. So 3 months is a quarter. And so a lot can change in the quarter if you plan it correctly. So that's how I felt this is going to go.
That makes sense to me. So you had noticed in your first week of curriculum, there's a difference between membership and fee-for-service. What do you mean by membership?
I had the same question. So when I learned about direct care, I was like, what does that look like for a podiatrist? And I had learned about DPC, direct primary care, and these were primary care doctors who, instead of billing insurance, they just charge the patient for a monthly membership. So it's like going to the gym. Right. You pay a low fee per month, and the things are there for you if you choose to use it or not. So it was almost all-inclusive care.
Right.
And then I thought, can that actually apply to a specialist? Where in podiatry do we have the opportunity to do a membership type of program where we take care of patients for a long time? With a background in diabetic limb salvage, I thought these are people who are lifetime patients. And so I started to play around with the idea of maybe a membership program so that I can at least retain their business as a recurring revenue for my practice, but also give them continuous care so they're not jumping in and out of the ER. So that's kind of where the idea of a membership kind of came from for me, modeling DPC and seeing how the people who might need long-term care might find a benefit to that. And then a fee-for-service, when somebody says fee-for-service, it could mean two things. It could mean you're still working with insurance because that term comes from insurance. You provide a fee for that service. But really, we've turned it around and say fee-for-service is just as needed. If you just need me for 1 to 2 visits, you pay for that office visit, and that's it. So instead of a membership, it's just you pay as you go.
That's fantastic. Tia, maybe I mentioned this to you, but I've had a concierge primary care physician since 2008. And he's in Denver, Colorado, where I was in practice, and I've retained him for my primary care, even though I moved to Miami for 7 years, and now I've been in Phoenix for 7 years. And I go back annually for all my workup and all my tests, and it's been probably the best medical decision that I personally have ever made in my life, for sure.
In your situation, was it only a monthly membership, or was it you paid your annual dues, but they also billed insurance?
Well, it was annual dues, but they did bill my insurance when I needed things covered, whether it was my prescriptions, of course, or whether it was an MRI or a CT scan. But they still do cash services also, like that new test for cancer, the Grail test, Graille, and ideally, it identifies cancers way before they present or have symptoms. So that's like a cash thing that we do, and it's $1,000 a year to do it. But that kind of thing's really neat because it opens up the world of possibilities for patients.
I really want to show the distinction between a concierge practice and direct care,
sure, because
they get mistaken for each other. Okay. Concierge is exactly how you described it. It's back in the day, it was usually for the wealthy people who wanted to use their insurance, but also retain that doctor just for themselves. So those doctors have the benefit of having fewer patients. So in that model, the doctor is still contracted with insurance, Medicare, PPOs, what have you, and they can still bill this membership service, which is a non-covered service, and get away with kind of double dipping in a way. Lower patient panel, but still using their insurance. Direct care is exclusively cash. Some people might be hybrid because they're easing out of insurance. There's a time frame for that. Or they are doing, not hospital work, but if they're doing locums and they have a contract with other facilities, they might need to stay on contract with Medicare, for example. So that's a hybrid direct care practice. But how that type of person make it work is they provide services, non-covered services. So those are cash, but still bill covered services. Direct care, in essence, no insurance billing whatsoever. So we've cut ties. Right. We can still order imaging, order labs, medications, send out referrals, but those are sent outside of our facility. So that's how patients can use their insurance benefits at those facilities.
Oh, that makes sense. Thanks for differentiating them? Because I think people are confused about that a little bit, and it's important to note. The second one I wanted to mention was in your course, defining your niche. When you're talking to doctors and you're asking them to define their niche, what are you referencing there?
The first question I ask doctors who are interested in direct care is, what is it that you want to do? And why would anyone choose you if they have insurance coverage? Like, what makes you stand out? And that's the common question for all business owners. What makes you unique? What's really challenging in medicine is that everyone's addicted to using their insurance. Even when we go to conferences, every single vendor will say, oh, this is the code to get it covered. Like, they don't even bother to think that maybe we don't work with insurance anymore. The trend is going to move in that direction. So we are all consumed with, is it paid by insurance or not? So it's really important to understand from a business perspective, what are you doing that makes people want to pay? What is so compelling that insurance isn't providing that they are going to seek care elsewhere? So defining your niche means, what are you doing to make you unique in a way that people are willing, able, and eager to pay cash for?
That makes sense. How do you differentiate yourself, right?
Mm-hmm. And that's the secret sauce that I can't answer for doctors. Doctors have to evaluate their community, find the missing pieces, find out why people are not using their insurance options, and then fulfill those needs.
No, that makes sense. I mean, it could be everything from dermatology to sports medicine to young athletes running around the soccer field with calcaneal apophysitis. I mean, they're all over the place, right?
Yeah.
So that makes sense to me. All right, very good. So then you also mentioned about finding your ideal patient. What does that mean exactly, T?
This question is a little bit trickier to get people to start thinking about, because not everybody who walks in your door is your ideal patient. And this is contrary to what we've learned through being a student, residency, fellowship. We were taught anybody who has insurance that walks through our door, we have to take care of them. But the reality is, in private practice, we don't have an abundance of resources, which means we can't see everybody. It's not financially feasible, and it's not even economical to do so, especially if we're not the expert of that thing they're coming in for. And within podiatry, there are super niches, sub niches in which, yes, we know the general of things, but if people are better served, let's say with a nerve specialist of the foot and ankle or a dermatopathologist of the foot and ankle, it's better to refer out to people who are truly the experts of those things. So defining the ideal patient is understanding who is actually going to pay cash. Who is that person? What is their persona? Why are they looking for cash? What needs do they have that is not being met with their insurance option? Or do they even have insurance? There's a ton of people who don't have insurance, who want easy access, who wants to just go to the barbershop and say, this is what I want, and they just want to pay for it and be done. No bills, months later.
That makes sense to me. There's no doubt that there's an element of care that is so frustrating. You call, you try to get an appointment, you can't get in for a month. The alternative to just come in, be seen, pay cash, be done is very appealing to people.
This is a huge thing in many different demographics. I'm Asian American, and in culturally speaking, lots of Asian people don't trust the system. They don't park their money in the bank. It's in a mattress. It's behind a picture frame. So people have money and they'll pay for things that are valuable. And oftentimes they use that cash for medical services. And that's why when people say, do you only serve the wealthy? That's not necessarily true. It's whoever prioritizes their health, and they will find ways to pay for it, whether it be money in the mattress or otherwise.
No, that makes sense to me. And there's no motivator, T, like pain. People are in pain when they walk and they can't ambulate. They're losing their independence. There's no bigger motivator than to get better.
The hardest workers are farm workers out here in Santa Cruz, Watsonville, I'm sure everywhere else. And if they lose time off of work because they're hurting, that's money loss, that's income loss. So this model serves everybody. Anybody who wants to pay for medical care, they can have it.
Makes sense to me. All right, your next module is getting patients in the door. What are you referencing there exactly?
How do patients show up on your schedule? So We think that putting up a sign is all that there is to it. Getting our degree, getting our second, third certification of something, people think that that's the only way to build your business. And as we know, with social media all over the place, we have to really be louder. We have to really tell people what we offer. We really need to invite them into our practice in the most frictionless way possible. So getting patients in the door really tells you how to find your ideal patients with the niche that you have. So it's the third or fourth module that I have in helping doctors find opportunities to network with referral sources, ideal referral sources, and market directly to consumers through social media or paid ads like Google ads or Facebook ads.
I've seen a bunch of your social media little shorts and highlighting different types of pain and orthotics and things, and they're phenomenal, T. And that translates directly into business for you.
Yeah. Thank you so much. It's something that people don't know you. They may know you have a degree, but do they like you? Why should they pay out of pocket? They really want to know who they're working with if they're going to spend money from their own pockets. And so this is the best way to do it, is to show up, provide value, and then invite them into the practice.
That's great. I love it. Yeah, hanging a shingle isn't the only way to attract patients. In fact, it's a very poor way just to build a practice. You got to do a lot more than that. All right. The next one I think is interesting. Asking your patients to pay, or how to get your patients to pay. It seems to me that that's kind of a foregone conclusion when they sign up. But is that an issue?
It's a huge issue because doctors don't know how to ask for money.
Okay.
Doctors never have the experience to talk about what it's going to cost the patient to do a surgery, to do a procedure, for a consultation, to order orthotics. We were never trained anywhere within our residency training or fellowship to have money conversations. So actually, the awkwardness falls on the doctor. The doctor provides the service, but they don't know what their value is. They don't know what that dollar amount translates to.
Right.
So how many of your listeners, I wonder, know how to charge a bunion surgery,
right,
whether it's insurance or not? Probably not too many, because we have relied on being employed and letting other people define what our value is. As long as the paychecks are coming in, most doctors are okay. But when it comes to creating a direct care practice, you have to be uncomfortable talking about money because it's something you've never done before. It's not that you can't, but you just don't really know where to start. I get a lot of doctors asking, how do you know how to price your stuff? And price is as subjective as buying a car. If you buy a used car, it's $5,000. If you go to Tesla, why is that $100,000? It takes you from point A to point B, but what other amenities are included? That's your job as a business owner to figure out. So learning how to ask patients to pay for your service really comes from defining your ideal patient.
Right.
You have to know who you're marketing to, and then you put the price point on it. Because the people who you think you're marketing to, let's say people who are using you because they're in network, they're not really your ideal patients in the sense that they chose you because they were not wanting to pay more out of pocket. They chose you because you were in network.
Right.
So now why would they pay you out of pocket when you're choosing to opt out? They're wanting those. That's the ideal avatars. There's somebody who maybe were frustrated with the system. Their needs weren't met. They're looking for alternative options. Those are your ideal clients. Those are the people who are willing to pay. And then when those people come to your door, then the conversation is a lot easier. When you're opting out and you're talking to your in-network patients, those conversations are incredibly hard unless you have a compelling niche to say, look, you're not going to find this anywhere else. This is the best thing for you. And here's my offer.
I like that, T. I like that a lot. And then, you had touched on a little bit earlier, what is your time worth? What is your expertise worth? And I can't help but think back to patent attorneys I've worked with that are charging, $500 an hour, or other professionals where you're paying for their brain power and their expertise and their experience of doing these things. Is that kind of the similar model you use with pricing your time, or is there a better model or different model?
I feel like that's the easiest, just your time in the beginning. So pick up the phone, call a lawyer, just see what their rates are. And they'll tell you, they won't bat an eye and say they're $500 an hour, they're $5,000 to retain.
Right.
It's as varied as, again, the price of a car. So physicians also have that power to demand whatever they think is going to fit their community, the needs of the practice. And I like to say doctors in general, $500 an hour is pretty normal.
I would agree. It seems to me it would be. So some of it, like, I don't know if I'm using the right terminology. Is it a self-image thing? Is it a perspective? Is it confidence and competence? I mean, well, what else goes into that, T? It's an interesting dynamic.
What else goes into pricing as a doctor?
Yeah.
I think it's a lot of reading. It's a lot of understanding what people need,
right?
How much it costs for you to run your practice, how long it took you to know what you know. Because some people think, oh, it was just a 15-minute appointment. Oh, it's just a signature. But how long did it take us to have that privilege to actually be able to use our medical license to sign off on a document? That took over a decade. So it's not just a thing. So we have to really compound all of the things that we invested in. Medical school is not cheap. We had to pay before we even got here. And so now we're having to pay back the debt plus interest. And so you really have to look at the grand scheme of things. How much did it take for me to get here, to sit at this table, to have this practice, to give the care that people are needing, and then put a price on that plus interest?
I like that a lot. You know, it's not what you do, it's knowing what to do. I'm having this flashback to when one of the safe, we had a safe in the house and we couldn't get it open. And we called somebody and they came in, and because he knew safes, he opened it up in about 5 minutes. And then we had a $250 bill. But it was totally worth it, right? Because without his knowledge and know-how, I still wouldn't be in that safe, right? So there's a lot of similarities there.
There was a marathon runner who said it took him 4 years to run under 4 minutes, right? And people think, oh, you're just paying for that 4 minutes. But it actually took 4 years to get to that point. And we have to think of our education, our knowledge in the same manner. It's not just a bunion surgery. It's how we know to take care of that problem, how we even got there, and how to take care of it when it doesn't go well.
Absolutely. No, totally agree. All right. I've got another topic here for us. How and when do you add different cash services, and what are they? What are cash services outside of, I think that's what you're referencing, outside of treatment protocols?
Cash services really means things that insurance doesn't pay for. We're talking about regenerative medicine, PRP injections, amniotic when it was in vogue, right. Prolotherapy. There's a variety of things that we offer that are actually conservative. And there is data for it. It's just not sponsored by industry, so it's not talked about.
Good point.
And therefore, it's less popular, and therefore insurance don't want to pay for it. It's really something that I think we need to inform our patients about, because if they're not going to get it from you, they're going to get it from google.com. They're going to get it from their chiropractor, acupuncturist, like whoever.
Right.
And everyone has a valuable part to play in educating the patient. So thinking about, if you're going to build your direct care practice, start thinking about what are cash services that people are already looking for. For us in podiatry, palliative foot care. A lot of people cringe over palliative foot care, but this has become something that I used to cringe about, but now truly love, because I'm connecting with people who value me, and I get to spend a lot of time with them month after month. This is long-term care. Right. And so that's how I created my niche. There are other things. There are functional medicine. There's minimally invasive surgery, stuff that isn't covered by insurance and people need. So that's what I mean by cash services. Okay. Down the line, when you start to opt out of insurance, you can also serve people who don't have insurance. So you can still do care that is covered by insurance. It's just that you disconnect that relationship. So I do bunion surgery and hammer toes and all those things. It's a covered service. So patients can ask for a super bill if you want to provide that, or they can pay cash and they just deal with it with like an FSA account, whatever health savings account they have. And you're just like, you do the thing that you need to do without more paperwork.
Absolutely. And no paperwork is so appealing. So you have a module on what, and it seems self-evident, what do you do to make patients come back, or how do you encourage them to come back? Your thoughts on that?
This is something that I didn't really think hard about in the beginning of my practice. We think that we just treat people, they're done, be gone, send your friends.
Right.
But business needs to have recurring revenue in some way. And that's where the membership option is really valuable, especially for primary care doctors. Specialty care practice, there are certain things that we can do like physical therapy, functional medicine, integrative lifestyle, things like that have recurring revenue, which is really important. But what we often kind of forget or just don't really understand just yet is how to get them to come back. Because sometimes people think they have heel pain and all they need is an injection because that's fast medicine, right? We talk about fast food. This is fast medicine in insurance. We're spending minutes with them. People want to get their problem solved. But what we all know is steroid injections, yes, it can kick out the inflammation, but have we talked about maintenance care? Have we talked about strengthening your feet so that this doesn't recur? Have we talked about appropriate shoes and when shoes need to be renewed? Or do we just give them an injection and call it good and they come back in a revolving door, never really getting better? And then we don't help the patient indefinitely. So ensuring patients come back is, yes, it's recurring revenue, but also we need to maintain some level of accountability, knowing that they're staying on track in their health journey. Right. We're trying to get them better. We're not just giving them a shot. We're ensuring that the things that they need to do are being done. And that is really important for any business.
And that makes sense. So I have a question for you in this regard for membership service, versus fee for service. It seems to me that it's easier for patients to follow protocols and address what you're asking them to do under the membership service agreement.
The membership, I really like it because they're tied to you and they know that they can just call you, text you, email you real quick, and you're there.
Right.
It's not going to be a middle person. It's not going to be staff that has continually turned over, and so they're having to rehash their medical history. So that's the benefit of a membership.
I like that. I like that a lot. All right, here we're delving into technology and the virtual assistant. Tell us about your use of a virtual assistant. How you got started? Was it a little bit rocky, and how'd you perfect it?
Yes, yes, and yes. We also didn't learn how to be a business owner, which meant hiring staff, being a good HR person, a good communicator, and like doing the non-physician stuff, learning on the fly. Very, very hard, but not impossible. So in a direct care practice, because we're not seeing 30 patients a day, we're seeing like 6 to 8. Our volume goes down, our overhead goes down, but we still need a little bit of help because I still want to be the doctor. So I started to work with a virtual assistant when I had insurance because they were doing insurance verification calls. Whatever needed phone work, that was a job for them. Answering the phone, making appointments, reviewing charts. That's how I used my virtual assistant. The first couple of ones were okay. They went as good as you can imagine for somebody who has no experience in hiring. So, there are things that we need to have in place, like teaching them how to do stuff, not just assuming they know how to do stuff. So even though I went through different companies that have trained virtual assistants for medical offices, there are still, personalization in each and every single different medical practice. So yeah, I had to go through a couple to figure out what I wanted and what I was looking for, but also what fits the practice. So I'm currently on my third or fourth virtual assistant, and she's been with me over a year now. Good. And I trust her to do everything from answering the call, making appointments, doing follow-up calls, even extending my reach as to marketing, reaching new offices, doing cold calls, whatever administrative tasks I need to have done, she can take care of. She also takes care of a lot of my coaching business things, like putting up a graphic for the podcast, putting things up on my website, links and things like that. So, if you can do it on the computer, that's where you can use a virtual assistant.
Yeah, I imagine that training manual for virtual assistant is in high demand. That's
so. I have created one with her, so in conjunction with her. So every time I tell her something, I said, make sure it goes in the training manual so that there's a table of contents that you can just click on. So things like, what if the patient asks, do you take insurance? There's a button for that. And then you would go through the script. And so if I hire new staff members, they can just review that.
I think that's fabulous. I mean, that training of front office staff, whether they're virtual or in person, is they're the first interface with patients, and they have to be welcoming, and they have to be knowledgeable, and they have to give the patient a seamless transition to the doctor. So kudos to you for perfecting that. That's important.
Not perfected. I'm still working on it, but thank you.
Perfect. Working on perfecting it. All right. Very good. Now you have another module, Achieving an Accounts Receivable Forever. Your thoughts and why that became a module.
Accounts receivable, what is that? I didn't know that in my first year of practice. I thought money was just flowing in. I thought checks were just going to show up. And then somebody said, well, you need to see how long that money that is owed to you is sitting in the pockets of 30 days, 60 days, 6 months. And I was like, what? That's more than my brain can handle. I have all these tabs open in my mind. Why do I have to keep track of money that's already owed to me? The service was already rendered. So that's the deal with insurance. And it's not unusual to have an accounts receivable of money owed to you in the thousands of dollars, 5, 6 figures, depending on how big your practice is. And that's simply because there's a general lag time with insurance paying the doctor. And there's a lag time between the doctor writing their chart note that has a consistent CPT and ICD-10 code. So there's a whole timeline before you actually get paid. And that's what the accounts receivable really means. When you have a direct care practice, people don't come into your office until they pay. They're paying up front or at the end of the visit. And then when that transaction is completed, there's no money waiting around to be cashed out. And so that's where you have an accounts receivable of $0. You're not chasing money. You're not waiting for money. And when you get the money, it's not being asked back. And it's not a discounted version of that money that you billed out. So whatever you charge is the amount that you will get on that day, and that's it.
I think that's fabulous. That's music to all doctors' ears to have no accounts receivable.
Right.
So let's delve into a little more personalized things. You have a module near the end of how do you define success for yourself. I think that's really important because everybody's got different needs, different visions, different skill sets. What do you tell docs in that regard?
It's really hard to get the big picture when you're kind of stuck in the nitty gritty, especially if you're building your practice. You're like, I need to get A done, B done. The to-do list is never ending for a business owner. But a lot of us get suckered into comparing our metrics with somebody else who might be on a totally different path. Okay. No two practices are ever the same. No two people are the same. So what is success to me as a mother, as a wife to a general surgeon is going to look very different to maybe a guy who is just only wanting to work on their business. So it's important to stay in your lane and to stay focused on your goals because only you have your goals to work on. Somebody else can't work on it, and you certainly can't work on somebody else's goals. I mean, you can if you're an employee, but when you own your practice, it's really important to have certain things in place. How do you define success? So many times I have doctors asking me, how much money do you make? And to me, the question is really asking, am I happy with where I'm at?
Right.
Because I could be making $1 million and be unhappy. I can be making $50,000 and be very happy. The spectrum is as wide as can be. So it's important for doctors to just kind of focus on what it means to be successful. So for me, success is having freedom in my time. I want to be able to be available to my daughter, to pick her up, to drop her off, do school activities. I also want to have the freedom to do medical consulting. If I'm done with clinic, I want to do other things that expand my horizon and have a bigger impact on the people I want to help. So every individual must define success on their terms so you don't get trapped in comparing yourself to somebody else when you're doing apples to oranges.
I like that. So much of everything is perspective. There's no doubt about that. So when you talk about putting it all together, I'm getting this vision and this picture that is unique to T, right? But you're also able to help other people. Talk about broadening your horizons. That must be very gratifying for you to help other docs get into direct care.
I used to think that something was wrong with me because even back in school, I was always interested in extracurricular activities. I could never sit in a classroom and just be okay with studying, taking a test, and then moving on to the next thing to study. That has always been incredibly boring for me. And I crave this creative freedom, just doing the small things that was joyful for me, like publishing an article, writing up research papers. There are all these things that I love about medicine that I really wanted to get my hands-on. But as early as I can remember, my husband, I love him, he was very focused. He was somebody who can just do the thing and be okay with life. We are so polar opposites in that regard. So I think it has given me freedom to feel good about who I am and how my brain works. And it's nobody else to compare it to, really. So putting it all together in this module, in this course, what it means is, after you've defined what success means to you, and then you put it all together, you're still human. This is just a small part of your life. Your life is not intended to be consumed with your work. You also have to make room for mental health. You have to make room for physical health, for other places where you can create an impact with less stress. We're trying to create a life that is meaningful, that isn't just defined by our degree. So, I try to bring in a more humanitarian approach with my course. This course isn't everything, for the one person. It's just part of the puzzle in creating a well-balanced life that you deserve, because we spent decades knowing what we know, and we might as well get paid for that, and we might as well get the respect that we deserve for that care.
Amen. I agree with you wholeheartedly, and I think that's wonderful. I commend you for your entrepreneurial spirit, your willingness to help others find their way in the direct care path. And gosh, T, I want to thank you for jumping on the podcast with me today.
Thank you so much for having me, and just for being inquisitive about direct care. This is a relatively new frontier. It's a renewal of an old frontier. This was how medicine used to be. And then third-party payers got involved, and then doctors abdicated their responsibilities to CEOs who have no interest in taking care of patients. And that's why we are where we are. Healthcare does not equal insurance, and it's really up to us physicians to reclaim that time for our patients and for ourselves.
Very good. Where can people reach you, T? I will put in my show notes your connections also, but do you have an email or tags on LinkedIn or Facebook that you'd like to share with our listeners?
The best way to get in contact with me, you can find me on LinkedIn, TEADPM, or my website, teadpm.com.
Fantastic. Well, again, I thank you for taking time out of your schedule to be on Dean's Chat. And to all of our listeners out there, if you're on Apple Podcasts or Spotify, please give us a 5-star rating. And of course, if you're on YouTube, please become a subscriber. And T, I'm going to send you one of these Dean's Chat cups. And
awesome.
What do you like to drink? Tea?
I drink all the things. I drink lots of tea.
All right, sounds good. Well, I'll send you a Dean's Chat cup. And until next week, everybody, cheers.